Welcome to PharmacyToDose, the critical care podcast, where we're discussing critical care and its pharmacotherapy in a fun and entertaining manner. And I'm your host, Nick Peters. Wherever you are and however you are listening, thank you. Now let's hear from our awesome sponsor, QXMD, before starting off today's episode. QXMD builds mobile solutions that drive evidence-based care in clinical practice. So check out READ for easy access to research personalized for you. Calculate for over 500 easy-to-use decision support tools, and Learn to earn CME online in minutes per day. Try them today at qxmd.com/apps. Again, that is qxmd.com/apps. Well, I certainly hope that everyone has been staying safe, healthy, and sane out there. And as we close out the month of May, who better to join us than Dr. Casey May, discussing the management of aneurysmal subarachnoid hemorrhage. Now, Casey May is a neurocritical care clinical pharmacy specialist at the Ohio State University Wexner Medical Center. She received her undergraduate degree at the University of Virginia. She completed her PharmD at the University of Kentucky College of Pharmacy and received her PGY1 and PGY2 critical care training at the University of Kentucky Healthcare. And we're so lucky that she took time out of her day to join us. Casey, how are you doing this evening?
I'm doing well, Nick. How about yourself?
I'm doing fantastic. We're holding down the Midwest here in Indiana and Ohio, respectively.
Yeah, absolutely. It's been a very rainy week, that's for sure. I'm ready for some sunshine.
Isn't that the truth? Now, You received your PharmD and then completed 2 years of residency at the University of Kentucky. So when you arrived at OSU in Columbus, how did they turn your blood back to red from blue?
That's a great question. I'm not sure if they actually have, to be honest.
Oh, so you eluded them.
I think I'll be a Kentucky fan for life, but it is entertaining to take part in the OSU football festivities for sure.
So that's what I was going to ask is, even though I know UK football is kind of on the rise, I was wondering if it's acceptable to kind of get the best of both worlds, which would be Ohio State football and University of Kentucky basketball. Is that kind of the route you chose?
Yeah, I think you can do that. And I'm pretty fresh still too, so I still have a lot to jump on the full OSU bandwagon, but I think I could.
Now, today we're kind of focusing on subarachnoid hemorrhages for our discussion, but let's kind of take a quick step back here and just generally speaking, what are the most common types of intracerebral bleeds? Is this just kind of one type of that?
Yeah, absolutely. So commonly you'll hear intracerebral hemorrhages or bleeds called iCHs. And I may say that kind of throughout the time that we're talking about the different types of bleeds. But generally, when you think about intracerebral hemorrhages, there's four main types, and kind of talking about them from the outside to the inside of the brain. The first one that we think about is an epidural hematoma. And that's usually when you have blood that accumulates between your skull and that outermost layer of the brain called the dura mater. And this frequently happens with different types of head injury and usually associated with a skull fracture. Most of the times these will be caused by tears in the arteries and is a surgical emergency. So delayed surgery can lead to permanent brain death or damage. And then moving in a layer, you have subdural hematomas. The subdural hematoma occurs when blood accumulates on the surface of the brain that occurs between the dura mater and the arachnoid mater. Typically, this, again, often happens in traumatic accidents or car accidents when you have, the brain or the head moving forward very rapidly and then it stops. You'll see this commonly in children when they are shaken. It's a common symptom of abuse that physicians can use. And then also, we think about subdural hematomas in two different manners, kind of like in the acute and chronic nature. And usually subdurals are more common in the elderly population, like the very, very old, usually on anticoagulation and that type of thing. And you'll see these acute or acute on chronic bleeds in these patients that aren't necessarily related to trauma. Then moving in a layer would be your subarachnoid hemorrhages, or what we're going to talk about today. So I won't spend a whole lot of time talking about those, but those are bleeds that happen between that arachnoid matter membrane and then the pia mater, that very thin tissue that surrounds the brain. And then moving into the actual brain tissue itself is when you would talk about something like an intraparenchymal or intracerebral hemorrhage. Sometimes that term is used both for the general ischemic intracerebral hemorrhages, and then also can be used for just the intraparenchymal bleed itself. So sometimes that terminology can be a little confusing, but that is a bleed that happens within that actual brain tissue itself. And most commonly we see these with hypertensive patients, but it's not uncommon to happen with trauma or injury, but it can. But most common, those patients that we see with intracerebral or intraparenchymal hemorrhages are associated with hypertension.
What a great kind of walkthrough in an audio format of that. I felt like, I don't know if you remember one of the old, like, I think it was called Osmosis Jones. It's like a really old cartoon, but they like move through the body. I felt like you were walking me through that there. That was fantastic. Now, are there different types of subarachnoid hemorrhage, or is it just you have an aSAH?
Yeah, when we think about subarachnoid hemorrhages in the kind of the brain world, we usually divide them into two different types, a traumatic and a non-traumatic. A traumatic subarachnoid, again, usually caused with head injury or trauma, and usually that bleed will be near the site of a skull fracture or a contusion of some sort. It often happens in the setting of other forms of traumatic brain injury, so they will come with like a traumatic brain injury and a traumatic subarachnoid, for example. And traditionally, we think of these being venous in nature. They can be. And the biggest thing that we should take away from this particular talk is that we will be mostly focusing on non-traumatic subarachnoid hemorrhages, and usually the treatment of traumatic subarachnoid hemorrhages does not follow those same lines of treatment as aneurysmal subarachnoid hemorrhage. For example, they don't use the same common standard of care treatments like using Nimodipine, for example, which is something most people are pretty familiar with when you're treating an aneurysmal subarachnoid hemorrhage. About 5 to 10% of all strokes in the United States are caused by what we call non-traumatic subarachnoid hemorrhages, and they usually affect patients that are younger than your more common subtypes of strokes, like ischemic or hemorrhagic stroke of that nature. Often, non-traumatic subarachnoid hemorrhages are usually caused by an aneurysm, but it also can be caused by other things like a vascular malformation or vasculitis. But about 80% of what we call non-traumatic subarachnoid hemorrhages are actually caused by a ruptured aneurysm.
Now, it makes sense what happens in traumatic subarachnoid hemorrhages, right? There's an accident, there's trauma there. But I think it may be helpful to maybe kind of walk us through what's happening within the brain kind of physiologically during an aneurysmal subarachnoid hemorrhage.
Yeah, when a patient develops an aneurysmal subarachnoid hemorrhage, they have bleeding from a known location, and usually that is an aneurysm. And aneurysms typically form at branch points or bifurcations along the intracranial arteries, most commonly within the circle of Willis, which is this kind of collection of arteries that kind of sit right along the bottom of the brain. When an aneurysm ruptures, it is an intracranial catastrophe. It pushes blood into the subarachnoid space at arterial pressure until the intracranial pressure kind of equalizes across that ruptured site, and then the bleeding will stop and a thrombus will form at that site of bleeding. This acute bleeding can lead to headaches, and depending on how much blood actually exited the arterial blood system, you can have altered mental status, or even a patient can develop coma. Additionally, when the bleed occurs there is an activation of the sympathetic nervous system, which can cause elevated circulating levels of catecholamines. And this is known to occur in humans with brain injury, particularly after subarachnoid hemorrhage. So you can have this kind of release of endorphins that can affect other organs. One of the more common things that we can see with patients are Not to get our focus too much away from the brain, but patients can present with what we call Takotsubo or broken heart syndrome. So this all kind of stimulates from this catastrophic event that happens in the brain, releasing these high levels of catecholamines, but can affect other organs, specifically in that case, your heart. And you can also see like flash pulmonary edema and that type of thing as well.
Okay, I like that. It's about the first 10 minutes and we have a neurocritical care specialist here talking about non-brain things. So I like this.
I know I'm going to get judged by my colleagues out there in the neurocritical care world.
Now, have researchers identified any risk factors, either modifiable or non-modifiable? Because this sounds, from what you described, this sounds like a pretty big problem if it happens.
Yeah, it's really interesting, actually. So intracranial aneurysms occur in about 1% to 2% of the population. So it's fairly rare. And usually we'll break out these risk factors into, modifiable and non-modifiable. Some of the modifiable known risk factors that we can educate patients on are to control their hypertension, to advise them to stop smoking, or abusing alcohol or sympathomimetic drugs. But also, when it comes to the non-modifiable things, we don't know as well. So we do know that there's a risk of intracranial aneurysm in patients who have a family history of having aneurysms. And usually this is defined as at least one first-degree relative who's had an intracranial aneurysm, with a greater risk if two or more first-degree relatives have that risk. Currently, the family history has no specific genetic link that we know of, but we know that it's very, very likely for someone who has these very close relatives that have cerebral aneurysms to develop a aneurysm themselves. Additionally, there are higher incidence in those patients who have specific connective tissue disorders, like Marfan's or Ehlers-Danlos syndrome, or patients with polycystic kidney disease. These are patients that do have common incidence of cerebral aneurysms. And then other things that we just can't control is, unfortunately, the female gender is more common to have cerebral aneurysms, along with the Black race or Hispanic and ethnic groups also have a higher incidence of developing a ruptured aneurysm.
Now, what's kind of the hallmark presentation of a patient who has an aneurysmal subarachnoid hemorrhage? Like, do they have a common complaint or finding? I mean, obvious, other than the obvious, which would be, a hemorrhage on imaging, of course.
Yeah, so this is an interesting thing to talk about because almost every patient that presents with a aneurysmal subarachnoid hemorrhage, they will come in and say, I'm having the worst headache of my life. This is very, very common to be, transcripted word for word into the patient's history and physical note that is placed. Another common description is called a thunderclap headache, or an onset of a headache that is very, very severe and reaches that maximal intensity within mere seconds. So it comes on very quickly and very hard. As someone who gets headaches often myself, I'm constantly evaluating to determine if this is actually the worst one that I've ever had. However, it may give some people some solace to know that only about 1% of all headaches evaluated in the emergency department are actually due to an aneurysmal subarachnoid hemorrhage. But it should be noted that there are some sentinel headaches that may be dismissed as migraines or headache and go without further evaluation. Therefore, it's very important that our emergency department colleagues, truly work up a patient for aneurysmal subarachnoid hemorrhage if they do come in with this description of the worst headache of their life, and really evaluating things like their family history or their past medical history or some of their comorbidities like hypertension and smoking to see if they do have some of those risk factors. Because if you do send a patient home who has that worst headache with a diagnosis of a headache or migraine, they could potentially rebleed, and that rebleed could lead to death or severe disability. Additionally, some other symptoms that we'll see are nausea, vomiting, photophobia, neck stiffness, and it can go to as far as just, complete loss of consciousness, depending on how severe the patient is affected by their bleed.
So is it every headache that you get that you wonder if you may have had an aneurysm rupture up there, or is it just the really severe ones? Because I think if I was in your shoes, every single headache, I would be like, oh gosh, like I'm going to die.
It's just the really bad ones. I do get migraines, so every time that I get a pretty severe headache, I do evaluate it. But so far, I've never actually had to be worked up. I think it's just my knowledge kind of taking over, taking over my actual patient symptoms.
Yeah, you start with your heart and then your head kicks in, which is a good thing. Now, it sounds like these are like, if you ask these patients to describe their headache on a scale of 0 to 10, that they're answering like 100, right? It's not like it's an 8 or 9. It's completely off the scale.
Yeah, that is my understanding. And, the unfortunate thing too is that these patients really suffer with headache almost their entire hospital stay too. So I think, we're going to talk about a lot of things of managing subarachnoid hemorrhage throughout, the next hour, but it's unfortunate that, we don't have a good grasp on how to manage these patients' headaches. And there's a few things that we can do, but they will actually have a pretty severe headache most of the time that they're with us in the hospital.
And of course, when you're the ICU team, right, we're worried about all of the down the line complications, and that unfortunately make it dismissed a little bit. But if you think about living with a headache for days to weeks, that would get maddening almost at a certain point.
Absolutely.
So is there a classification or some sort of scoring system to help predict kind of the outcome in these patients?
There's a variety of different grading systems that can correlate clinical status of a patient at the time of presentation with the long-term neurologic outcome. The two most common used grading scales are the Hunt-Hess classification and the World Federation of Neurosurgical Societies classification. In both symptoms, they use the severity of encephalopathy as the major determinant of the grade. And then aneurysm rupture produces this because the aneurysm rupture produces this widespread kind of brain dysfunction, if you will. The Hunt-Hess score is probably the most common and the one that people would be most familiar with. It is the oldest. It was developed in the 60s. Or so, and the scale ranges from 1 to 5, and it's used as a predictor of prognosis or outcome, with a higher grade correlating to a lower survival rate. So, for example, a Hunt-Hess score of 1, a patient would be relatively asymptomatic, maybe have minimal headache or slight neck stiffness, and their mortality rate at that time would be about 30%, actually. And then that ranges to a Hunt-Hess score of 5, where a patient presents in coma, already has a lot of rigidity, and their mortality is approximately 90%. But as I kind of mentioned before, this scale was really developed in around the 60s, and so our treatments and standards of care are very different than what they were then. So this hasn't been, redone, but I would imagine that these mortality rates would drop a little bit. But still holding true that how you present on arrival, whether you have 1 or has 5, that would change your expected mortality from the subarachnoid hemorrhage. The World Federation of Neurosurgical Societies classification, or you'll commonly see WFNS grading, uses the Glasgow Coma Scale in the presence of focal neurologic deficits, and this was developed in 1998. They don't have any specific mortality associated with that, but again, it kind of ranges from a scale of grade 1 to grade 5, where grade 1 would be a GCS of 15 with no motor deficits, where grade 5 would be a GCS less than 7 with or without deficits. So most likely you probably would have some focal deficits with that GCS. So those are two that work on kind of that clinical presentation and kind of can help you predict mortality, if you will. But another important scoring tool that we often use in contact with subarachnoid hemorrhage is the Fisher scale. And the Fisher scale is different from the Hunt-Hess or the WFNS, where the Fisher scale is actually used to identify the amount of subarachnoid hemorrhage or the amount of actual blood that's seen on the CT scan. And this is helpful in predicting the occurrence and severity of cerebral vasospasms, which is a complication of subarachnoid hemorrhage. And this ranges from a grade 1 to a grade 4, where a grade 1 would kind of demonstrate that there's little, if not no, subarachnoid blood noticed, and no intraventricular hemorrhage, with an incidence of symptomatic vasospasm right around 21 or so percent, where a grade 2 would be more diffuse blood that's seen with a higher incidence of symptomatic vasospasm. And then grade 3 would be, a very thick amount of blood around that subarachnoid area, so greater than 1 millimeter thickness, with no intraventricular hemorrhage. And a grade 3 actually has the highest incidence of symptomatic vasospasm at around 37%. Where this grade 4 is a little confusing because really it just tells you that there's intraventricular blood. So you could have a patient who has little or minimal blood in the subarachnoid space, but they have a lot of intraventricular blood. So their vasospasm rate is a little lower than what you would see in a grade 3, because we believe it's that thick clot that actually is correlating with that symptomatic vasospasm. And there's been a modified scale that's developed to kind of help with those differences, if you will, which we won't get into that. But you may see that some places report a modified Fisher score, which would basically kind of take into account some of the issues with the Fisher score that I just talked about.
And one thing I want to highlight from what you said is that even if you take into account, okay, we'll drop the, predicted mortality, a little bit, that's still, 20 to 25% of those patients, may not make it through their hospital stay. So just showing, no matter what grade they're presenting with, that this, this is a, problematic kind of medical emergency when they come in. And regardless of how severe it is, it definitely seems like an all hands on deck kind of procedure.
Absolutely. And I think, they present because of the bleed, but, as we'll talk about, cerebral vasospasm really kind of contributes to the highest percentage or part of mortality that we see in these patients. And that's something that will develop, a week into their stay. So it's not something that we would, know or be able to predict really on day one.
Now, when these patients present acutely, there are, multiple critical care issues, that we, definitely keep in the forefront of our mind, right? Cerebral edema management, blood pressure, controlling bleeding, among other things. Are all of these equally important, or is there some sort of kind of order of operations when they present in terms of what is most important to help manage in these patients?
Yeah, you're correct. These patients can present and be very critically ill, or they can present with just a headache. And it really depends on how, if the patient has, multiple interventions going on at the same time, and depending on how they present, depending on, how I would prioritize my management. But we know that the risk of rebleeding or re-rupture of that aneurysm is the highest within the first 2 to 12 hours, and factors associated with aneurysmal rebleeding include longer time to aneurysm treatment, worse neurologic status on admission, the larger the aneurysm, and then a systolic blood pressure greater than 160 millimeters of mercury. However, if you made me choose, I would say most importantly, we should think about managing the subarachnoid in a way to get the patient to the OR, to the angio suite, to secure the aneurysm first. But obviously that's out of the pharmacist's control. So in our toolbox, I think the most important thing that we can do to prevent rebleeding is to help control the blood pressure. Another equally important thing that we don't see often in subarachnoid hemorrhage patients, just because they don't carry all these comorbidities usually, would be anticoagulation reversal. So if they happen to be on an anticoagulant at home, it would be important that we kind of assess that, whether they need to be reversed, whether it's warfarin or a novel anticoagulant. But honestly, like, this reversal issue doesn't come up that often in aneurysmal subarachnoid hemorrhage patients, because usually they may just have hypertension, or they may not even have a true diagnosis of hypertension yet, because they don't see a doctor, and they're usually fairly young as well, in that 40 to 60-year-old range. So as a pharmacist, I would say our most highly important thing that we should be doing is controlling blood pressure, but also, encouraging our neurosurgical colleagues to take care of that aneurysm being the highest priority.
Well, let's do this. We're both pharmacists. Let's talk about the pharmacist wheelhouse, and then we'll give the surgeons their time, and we'll talk about kind of managing the rupture and the bleed and things. So, you kind of hinted at this, but let's just kind of re-emphasize it. What is the initial blood pressure target, and is it a range in patients who have aneurysmal subarachnoid hemorrhage?
Yeah, so the general agreement is that we know acute hypertension should be controlled. So we all agree on that. But the actual number is not well defined. So technically, the aneurysmal subarachnoid hemorrhage guidelines from stroke say that we should maintain a systolic less than 160 millimeters per mercury. And that is, from that data that we know that if it is above that, then we can see higher incidence of re-rupture. However, most centers that, I've been at, and that you'll see and talk to other pharmacists, most of them strive to keep the systolic less than 140 until the aneurysm is secured. So all of these blood pressures that we're talking about is until that aneurysm is secured. So guidelines say less than 160. I would say in practice, most of us are shooting for less than 140.
Now, do we have any evidence to suggest that we should be trying to use any specific antihypertensive agent in these patients, or is it just, hey, we need the number to be less than X, and however you get there is fine?
The short answer is no, but we do have a variety of options available. Nicardipine, clofidipine, labetalol, sodium nitroprusside. Some reports state that nicardipine may offer a smoother blood pressure control or more controlled, steady blood pressure control. However, we do have data demonstrating any differences in the clinical outcomes depending on which agent you use. So the takeaway that I would say is, use a drip, so something that's titratable, and whatever is the closest to you. So, if you keep nicardipine drips in your automated dispensing cabinet, whatever your brand is at your hospital, then that's what I would grab just to gain control of that particular patient. There was a retrospective study out of Columbia University Medical Center that suggests that nicardipine, labetalol, and or the combination appear to be equivalent in maintaining blood pressure within the goal and minimizing the variability in that population. And they included both intraparenchymal hemorrhages and subarachnoid hemorrhage patients. But they did show that nicardipine was usually faster to gain control than labetalol. But again, there was no clinical outcomes to support one over the other.
So maybe if you're an institution that kind of compounds nicardipine on demand and doesn't keep it in the automated dispensing cabinet, that maybe you can kind of use that PRN IV labetalol while the IV room is getting that infusion ready.
Yeah, absolutely.
So do we have any, it sounds like, okay, it could kind of be, whatever, works best for the majority of patients, what you can get to quickest. But are there any concerns or risks with any of these antihypertensive agents or things that we specifically in this neurocritical care population, things that we want to keep in mind?
The biggest concern is going to be lowering that cerebral perfusion pressure, which may lead to cerebral ischemia in those patients who do have an elevated ICP on arrival. A lot of times we don't know what their actual intracranial pressure ICP is. But we do have a cohort study that demonstrated that there was no association between the use of nicardipine for blood pressure control and reduced brain oxygen tension. So I would say, there are some concerns kind of immediately because your brain and your body's very smart, right? So if you're not perfusing your brain, your blood pressure is going to increase. Like that's what your body's going to do. But I would say until we get the aneurysm controlled or the aneurysm secured, the biggest thing that we want to focus on is getting that systolic less than 160 until we can get them to the OR, to the angio suite. And then, managing ICP in a different way, whether it be osmotherapy or something like that. If we have evidence on a scan or if we have placed the monitor already and we know that their ICP is high.
So based on what you were kind of talking about in terms of keeping the ICP and CPP in mind, at least for initial or empiric treatment, one of the things that I was taught and learned is, the use of sodium nitroprusside or nipride can increase your ICP. So is that something that you all routinely avoid? Is that something that, maybe has been debunked from when I learned it?
Yeah, so you'll read different things based on sodium nitroprusside, but it's definitely, we really don't have to use it anymore, to be honest, because we do have a lot of agents kind of available with nicardipine, and then, having clovidipine available now and labetalol. So honestly, you don't really see it used very much at all anymore.
So it's kind of a scenario where, yeah, you might be okay, but there's so many other options. Why would you risk it, kind of?
Mm-hmm.
Okay.
Yeah.
Now, one of the other things, right, you're mentioning the ICP, and kind of going along with that is the cerebral edema. So, compared to maybe other hemorrhage like intracranial hemorrhage populations, do these patients have a similar risk of cerebral edema, or is it kind of universal, the risk across all types of head bleeds?
So it's really, we don't really have like a percentage, so I can't really tell you how many will have elevated ICP compared to other types of bleeds, but the risk of an elevated ICP, specifically in the subarachnoid hemorrhage population, is really directly related to the amount of blood that the patient has. So obviously the patient has more blood present than another patient, and their risk of having an elevated ICP will be higher just simply because that blood is occupying space that isn't normally filled with blood, right? In the Monroe-Kelly doctrine. Many times patients with a lot of blood will present with a higher Hunt-Hess score, where they'll be more comatose, and they will likely have elevated ICPs, and we would treat them empirically. And we don't necessarily have to have a monitor in place to know that their ICP is high, because we can see that from the scan, or we can take that from their clinical exam.
Now, ultimately, is your ICP management the same? Like, do you have the same principles in terms of, osmotherapy, sodium targets, et cetera, or do you do anything unique?
Yeah, I know you spoke with Aaron Cook a few weeks ago regarding the new guidelines for the acute treatment of cerebral edema, just published by NCS, and those guidelines are great. But as he mentioned, we don't have great data across the board on what to do for patients with elevated ICP. And I would say specifically for aneurysmal subarachnoid hemorrhage patients, I would utilize sodium chloride boluses, either 3% or 23.4% sodium chloride for ICP treatment, in a manner in which we call symptom-based treatment. So, not necessarily targeting a sodium, but, treating when we know that we have a decline in neurostatus, or when we have an ICP that has spiked on your monitor, if you have that available. If you have a patient who already has a high sodium, so let's say it's 155, 160, mannitol is equally a very good option for ICP management. And largely there isn't a difference between mannitol and sodium chloride when given at equal osmolar doses. When it comes to ICP controls, that's really the biggest thing is, again, in most of the neuro emergency world, use what you have closest to you, and just make sure you're being smart about the dosing and making sure that you're providing the patient equal osmolar dosing of whatever it is that you choose.
I like that you are keeping the KISS method available for us non-neurocritical care pharmacists. You're just keeping it simple, and you make it easy for us in terms of the ICP management kind of across populations. So thank you.
Of course.
Now, when in these patients, when is their cerebral edema risk the highest? And does that change at all kind of throughout their ICU or hospital course?
It can. Oftentimes we see more issues with elevated ICP when the patient has the presence of intraventricular blood in addition to their subarachnoid hemorrhage blood. And this is primarily due to the clotting of the ventricular system and the inability to have kind of that normal bulk flow of CSF. So this would be more in that initial presentation or the first few days. So oftentimes patients with a subarachnoid hemorrhage with intraventricular hemorrhage, we'll need an EVD so that we can continue to drain that excess CSF to help with ICP management. But then again, you can see some delayed cerebral edema related to ischemia, specifically if a patient develops severe vasospasms. So if they, have a severe vasospasm that causes them to develop an ischemic part of their brain, then now that ischemic tissue would be at risk of developing cerebral edema. And this is obviously kind of later in that hospital course around day 7 to 14.
Now, you mentioned that a lot of these ICP issues stem from the fact, right, that they have blood in their brain, and if there's something there, right, the pressure is going to follow it. So really the only true definitive treatment, right, for this hemorrhage would be either, surgical or endovascular repair of the aneurysm. And then even, re-ruptures can occur. So something needs to happen. Now, I'm sure we could spend an hour or even longer truly just discussing this manner, but maybe we could do the the TLDR, too long didn't read, and we can kind of do a high level compare and contrast kind of surgical clipping versus endovascular coiling of the aneurysm.
Yeah, we could spend a very long time talking about securing ruptured aneurysms, and since the majority of your listeners are pharmacists, I don't think they would appreciate that. But I do think, as you mentioned, it is a very important part of these patients' management. So it is important for everyone to understand the importance of securing or repairing the aneurysm. First, it's important to understand that if a patient's aneurysm were to what we call re-rupture, re-bleed, that this is very devastating. So it kind of highlights the reason why we need to escalate this care. And, a while ago, clinicians used to not even intervene on patients who presented with a Hunt-Hess score of 5. They would literally put them in a dark room, control their blood pressure, reduce stimulation, and just make sure that they made it before they would even take them to secure their aneurysm, because at that time they were having to do what we call surgical clipping. And that could also cause the patient more harm potentially. But now we know from clinical experience in randomized trials that treatment of a ruptured aneurysm is safe, and it eliminates the immediate risk of aneurysm re-rupture. So we don't necessarily sit on these very severe patients anymore. We kind of treat everyone equally depending on how they present, and making sure that we secure their aneurysm as fast as possible. So the first type is, as I kind of mentioned, is surgical clipping of the ruptured aneurysm, which requires opening the skull and performing a craniotomy. Then with, operating microscopes, they get down into the cerebral arteries at the base of the skull. And once they find the aneurysm, they will place a titanium clip across the neck of the aneurysm to mechanically close the sac at its neck while preserving blood flow through the adjacent arteries that are functioning as normal. So again, very invasive, this is what we typically think of as brain surgery. And very delicate work by the neurosurgeon. The second option is endovascular treatment of a ruptured aneurysm, which involves navigating a catheter under fluoroscopy to the entry point of the arterial circulation, typically the entry through the femoral artery, up to the parent artery of the aneurysm. So they go, basically from your femoral to your brain, which I always find pretty remarkable.
Yeah.
And then they long. Right? It's a long way to kind of take that little catheter. So then a microcatheter is advanced into the aneurysm sac, and metal coils will be deposited into the aneurysm lumen. And they'll continue to do this until, they completely occlude that aneurysm, and they're constantly shooting dye to kind of see if they've filled that aneurysm sac with coils. And then this will induce a thrombus in the sac of the aneurysm, and that would occlude the aneurysm and prevent any immediate risk of re-rupture. Endovascular therapy can be paired with a stent for aneurysms. So in aneurysms in which we call wide neck aneurysms, a stent needs to be placed there to prevent that coil mass from falling into the artery. And we call this stent-assisted coiling, and often requires patients to be on dual antiplatelet therapy. Additionally, there's a brand new device called a woven endobridge or a web device, which can be used to occlude these wide neck or multilobular aneurysms without requiring a stent. And this is fantastic because this would eliminate the need for patients to be on dual antiplatelet therapy. They only require aspirin if a web can be placed, but it's a brand new device and isn't necessarily available everywhere. They're still, going center to center to train neurosurgeons on how to place it. It's important to know that there is a randomized controlled trial looking at whether we should coil or whether we should clip these patients. And basically, if an aneurysm could be treated either way, then it is preferred to coil patients when you can. But if you're interested, you can, read the aSAH trials, which we can link in the show notes, because they evaluate patients at 1 year and at 7 years on follow-up. And at 1 year, basically, they saw that patients who were coiled maybe had a better, outcome because they didn't have that surgery and they maybe recovered a little faster, but really there was no difference at 7 years. So really it's important to, let the neurosurgeon decide how they should approach this particular aneurysm and just make sure that we're securing it as quickly as possible.
And so depending on what hospital or health system you're at, you could potentially see surgeons or like your neurosurgery team really kind of clipping or coiling depending on the surgeon and the type of bleed that it is, or the how big it is or whatnot.
Yeah, so you will likely, most centers will have the availability to do both, and it will be up to the neurosurgeon to decide, what is the best way to approach this particular aneurysm, whether it's by endovascular treatment or by surgical management. And really that's their wheelhouse to figure out, which is best for that particular patient, because the data we have basically explains there's no difference. But if you can get there by coiling, it is preferable, especially with the outcomes that they saw within that first year.
Yeah, if you want to argue with a neurosurgeon on how to do this, be our guest, and then please let us know how that went for you.
Yeah, I'll argue with them on some things, but not that.
Yeah. Now, the initial care of these patients is obviously focused on the acute management of the hemorrhage and its downstream effects. But, as you mentioned, something that's, always in the back or forefront of our mind is we're concerned with preventing kind of the delayed cerebral ischemia and cerebral vasospasms. So how do we monitor for these complications?
So first, just to kind of explain what cerebral vasospasms are, I know that I had a difficult time wrapping my head around this as a student and an early resident, but cerebral vasospasms are basically narrowing of the angiographically visible cerebral arteries after a subarachnoid hemorrhage. So you'll see these arteries just narrow or get much, much smaller. And it occurs in actually about 70% of the patients with an aneurysmal subarachnoid hemorrhage. The process generally takes about 3 to 4 days to happen after the aneurysm ruptured. And the peak time period that this happens is around day 7 to 10 and usually resolves by day 14 to 21. It really depends patient by patient. Delayed cerebral ischemia is a clinical syndrome of focal neurologic deficits that develop in patients who have this cerebral vasospasm. And you can see this in about a third of patients. It typically, again, happens within that 4 to 14 day window and is the major cause of death and disability after subarachnoid hemorrhage has occurred. So, it's not always the bleed that causes the high mortality and morbidity in these patients. It's actually this delayed cerebral ischemia. You asked how we monitor. So we monitor for vasospasms usually daily by completing what we call transcranial Dopplers or TCDs. And this is done every day. It's simply an ultrasound that a very skilled technician completes at the bedside, and they measure the velocity of the intracranial cerebral arteries. So simply, as the velocity of the intracerebral arteries increases, then the risk that that vessel is narrowing is very, very high. And so the way I like to explain it to students and residents is, have you ever grabbed a water hose and put your thumb or your finger over that opening? And when you do, the water comes out faster and goes further, right? So the velocity of that water is increasing. So the same thing happens in the cerebral vessels when they narrow. So we think of, narrowing as the patient's probably not getting as much blood, but the way we identify that is that blood flow is increasing because that vessel is narrowing in size. So it is important too that we note that just because the velocities increase does not mean that the patient is a danger. So we really like to trend these numbers. So that's why we get them every day. And we'll start basically, hospital day 1 or 2 of getting TCDs. And so we'll get this information every day and we'll look at the trends. And you really take these numbers that you get from the TCD and you use it in conjunction with the patient's neurologic exam. So for these patients, they're often getting a full neurologic exam every 1 to 2 hours, even throughout the night. And so we are very attuned to if these patients have any sort of cerebral ischemia secondary to their vasospasms. So, oftentimes you'll see deficits that can range from the patient, an hour ago was able to tell us where they were and who they are, but now they can't. They don't understand they're in a hospital. Or they could develop facial droop or arm drift, or they could have complete altered mental status. So it really just depends on where that spasm is happening and what area of their body that it actually affects. So obviously, this is great in patients who are able to talk and walk and do an exam, but we do have patients who present comatose and may be like that for a while. So we rely more heavily on those TCD numbers and just kind of the gross motor exam in patients who are not able to kind of participate fully in a neurologic exam. So if a patient develops an increase in TCD velocities and has a focal neurologic deficit, then there's a couple of things that we can do. They may go to just have like a CT angio scan done to see, or CTA to see if we do indeed have narrowing of those vessels, or potentially if the neuro exam is bad enough and the TCDs are high, then the neurosurgeon may decide to take them straight to the angio suite. And there's interventions that they can do that we'll talk about, but that is really the gold standard of identifying cerebral vasospasm is to simply go back into the angio suite, like when they were coiling the aneurysm, and go in under fluoro and specifically look at each of those cerebral arteries to see if they are narrowing.
So if and when patients experience cerebral vasospasms, is there any pharmacologic treatment?
So this too could be a very, very long conversation, but I'll kind of summarize some highlights. There have been many things that have been evaluated for the prevention of vasospasms, and most, if not all, have failed, right? So statins, magnesium, nimodipine, aspirin, all of these things, we have not found anything to prevent that initial spasm to occur. Additionally, we like to think about things like AAH therapy. So that's a common thing that's thrown around when you hear subarachnoid hemorrhage come up. Today, we don't truly practice AAH therapy, and that originally stands for hypertension, hypervolemia, and hemodilution. This process can be viewed as a therapeutic treatment or a prevention strategy, and most centers don't use AAH as a prophylactic mechanism anymore. We simply just allow the patient's blood pressure to basically do whatever it wants. So, we talked about blood pressure goals immediately and early on in their care when they present to the emergency department. But as soon as that aneurysm is secured, about 24 hours after, depending on what type of procedure they had, we'll let the patient's blood pressure go up to 220, and just whatever the patient needs. We're just not going to, purposely keep that blood pressure down because the body's smart enough to provide what it needs to the brain. And then we'll keep the patient euvolemic, so we don't make them hypervolemic anymore. But when a patient does develop vasospasms, we can continue to keep the patient euvolemic. So again, we don't necessarily push their volume status, but we may push their blood pressure. So we may use that hypertension component of AAH therapy to augment the systolic blood pressure. So, usually we'll increase it by 10 to 20 millimeters per mercury above whatever their baseline was when they developed these symptoms. And you can do this. It's a really neat little bedside trick to do, because if you have a patient who can participate in an exam, you can put them on a vasopressor, push their blood pressure up 10, 20 millimeters per mercury, and then maybe they'll remember, or not remember, but now they'll know, where they are and who they are, or they'll lose that drift that they had in their right arm. So it's a really cool bedside test that you can do for these patients.
Whoa, yeah. The first time you had to have done that had to have been wild, right? I'm guessing you were in training when you did that. I'm just imagining it that's much better than when you're bedside for the adenosine administration, right? Where it stops. This seems like a better kind of bedside watch.
Absolutely. It's very cool to see. Unfortunately, it doesn't always work, so we may continue to kind of escalate that number. We started at, the patient was sitting at 120, so we pushed them to 140, and then we'll go to 160, 180, and it's not helping. And so then you kind of have to move on to other interventions. But yes, when it does work, it's very cool to find the patient's sweet spot blood pressure. And it's fun. It's definitely fun for trainees to see as well. And then we don't really do or recommend hemodilution anymore at all, which basically just means to drive down the red blood cells. We now know that this can reduce the oxygen carrying capacity for obvious reasons, which isn't ideal for these patients. So AAH therapy is kind of gone by the wayside, but that hypertension component we use pretty frequently. So additionally, they can, in the angio suite, administer intraarterial medications at the site of the spasm. Common medications here are verapamil, nicardipine, and milrinone. It's commonly called that the patients are getting squirted, is the term that they'll use in the angio suite. Yeah, right. So they get a squirt of these drugs. And again, it's very common that if a patient goes for to evaluate their vasospasm in the angio suite, that they'll get one of these three medications. So as a pharmacist, you can really help when they get back. They may be hypotensive, and trying to help assist with that. Additionally, if the patient has an EVD, we can administer either nicardipine or sodium nitroprusside through the EVD. IV medication options are milrinone. There's this protocol called the Montreal protocol that we can use for using milrinone. Magnesium sulfate drips have been used, and IV sildenafil. Additionally, there are a lot of treatments on the horizon with ongoing trials. Specifically, we have classification, which has an active trial, which is an endothelin receptor antagonist. And then also there's a couple of trials going on with heparin, actually. So again, cerebral vasospasms, there's not much we can do. It's really about supporting the patient, and then hopefully we'll continue to search for something that will help manage either the spasm once it develops or prevent the spasm. But we just don't have anything really to support much here at this time.
And it sounds like if you're using using the squirts, which I'm definitely going to steal, that maybe my favorite part of the whole episode so far. When you do that, it sounds like, from a medication safety perspective, it's really probably important to have, whether it's order sets or power plans or what have you, to make sure that these things get ordered in appropriate doses and things. Would you agree with that?
Yeah, absolutely. And a lot of times it's really going to be on our OR colleagues that are seeing this. So we don't necessarily have a lot of these agents set up live in our normal ordering system, but they're kind of hidden in the OR order set, making sure they have the right product and like you said, the right dosing. But really it's our OR pharmacists who are really manning this, obviously with the help of of neurocritical care pharmacists to help them kind of work through those orders. But it is something that we do try to hide from the live system from everybody else, because you don't want these ordered inappropriately. So there's a lot of medication safety aspects to go along with these agents.
You know, one of the central themes I've gotten kind of throughout our discussion is just how devastating of a disease this can be, and how really, you know, everything's being studied, and there's just not been a whole lot of positive trials focusing on kind of treatment or prevention pharmacologically. You know, because currently we really only have, you know, one intervention that helps improve those patient outcomes, which is Nimodipine. So in aneurysmal subarachnoid patients, what does Nimodipine do? What is kind of the research shows why it's so important in these patients?
So Nimodipine was originally studied because the thought was that because it is a calcium channel blocker, that it would help prevent vasospasm by relaxing that vessel or keeping that vessel relaxed. And what was identified is that it actually didn't prevent vasospasms at all. Actually, the number of patients that developed vasospasms was very similar. So there were 19% of the patients in the Nimodipine group and 16% of patients in the placebo group. But what we did see from that original study is that patients on Nimodipine had fewer cerebral infarcts and had improved outcomes after subarachnoid hemorrhage, thus deducing that delayed cerebral ischemia was really what was reduced here rather than the vasospasms itself. So the caveat here is we're really not sure how Nimodipine actually works in subarachnoid hemorrhage. Many people think that there's some sort of pleiotropic effects, whether it's the calcium blocking part of it, that plays a role in to help support the ischemic brain. But honestly, like, we're all kind of pontificating at this point. We don't really have a good reason as to why Nimodipine was successful in this trial. But as you kind of mentioned, it's really the only thing we have to hold on to. And it is standard of care in all patients. And so Nimodipine is what we do for these people.
So it's a standard of care. It's a medication that we'll kind of use in everybody. So let's drill down. I think there's a couple probably common questions that come up in these patients with Nimodipine. So let's kind of dive in a little bit here. You know, you mentioned Nimodipine being a calcium channel blocker, which can obviously bring down your blood pressure. And when we're concerned about CPPs and blood pressures, right, sometimes I'm guessing that some of these patients may require the use of vasopressors. So do you use these agents concomitantly? If they're on pressors, do you hold it? Do you just go up on the pressor dose? Kind of what's your management strategy in those patients?
Yeah, this comes up a lot, Nick. So, and I'll tell you how I manage it, and I'm sure you can talk to someone else and they're going to give you a different perspective. Mm-hmm. But when we talk about vasopressors in subarachnoid hemorrhage, again, you know, most of the time, I would say, you know, they can be on vasopressors for hypotension, obviously, because they have developed like septic shock or something else that has happened throughout their stay, or they have Takotsubo when they arrive, that type of thing. But oftentimes we are using vasopressors in this population to augment or increase their blood pressure, you know, above normal, to help prevent that delayed cerebral ischemia that we see with vasospasms. So my usual approach is to continue Nimodipine in patients who are on a low dose vasopressor for hypotension. And if the doses start to escalate and they need another pressor, then I'll advocate holding the Nimodipine while the vasopressor is on until we can get the patient back to their baseline blood pressure or get them down on one pressor. Because we know that we think that Nimodipine works some other way. It's not because that it's relaxing that vessel, right? So maybe it is that calcium channel blocker that we need on board to help prevent that ischemic tissue from forming. So I try to keep it on as long as I possibly can. But if we do have escalating doses or we're adding on multiple pressors, then I'll recommend to take it off. If the patient is on vasopressors to augment their blood pressure, just to help in perfusion, then usually I'll continue Nimodipine, because usually these patients only need small amounts of vasopressors to help augment their pressure. So usually when we're augmenting people with vasopressors, you're not going to see those very, very high escalating doses like you would see in septic shock. So traditionally, I'll try to keep them on. If you do have the rare patient that's requiring high doses or they're very sensitive to nimodipine, then I'll hold it until we can get it resumed back whenever they come down on the vasopressor or back to 1, if that makes sense.
Absolutely. Now, kind of leading off of that, I want to follow up based on something that you said at the end, that patients, certain patients may just be sensitive to nimodipine. Now, not necessarily saying, like the scenario we kind of just laid out was those patients were on vasopressors, and the scenario you laid out of augmenting their MAP is exactly what I was kind of thinking. But because you don't want their blood pressure management so important in those patients where blood pressure drops, right? Do you ever alter your dosing regimen of nimodipine? Because kind of the evidence-based regimen is 60 milligrams by mouth every 4 hours. Does that ever change?
Absolutely. So the dose is Q4 to 1 days, right? Why? That's how it was studied in the original trials, right? And variants for most how we dose things. And you will have to be extremely sensitive, and that's kind of waking you bedside to really help us out here. Pounding, and the systolics are 100s, and we're talking about pressure. My first question to the bedside nurse is, okay, did you give nimodipine or did you systolic drop and gave nimodipine? And frequently their answer is yes, I just gave it, 10 minutes, an hour ago. And so this is where I'll recommend reducing the dose to 30 milligrams every 2 hours. Our nurses don't like having to give a medication every 2 hours, but we do recommend this quite often. We feel more comfortable with it because we're giving the same total 24-hour dose, right? They're getting the same amount of drug throughout the day. Do we have literature to support this? Not really. But it does make us feel a little more comfortable that they're getting that same 24-hour dose. Additionally, like something just to mention that if we do have to hold nimodipine due to significant vasopressor requirement or they're just not tolerating it, when I resume nimodipine, I will not add extra days on to the nimodipine therapy. I will still continue the medication for 21 days from their ictus or from when they bled originally, because usually just because you stopped, it doesn't mean their vasospasm window has extended, right? So I still don't need any more therapy than the 21 days. So that's just one unique thing to highlight if you do have to stop or augment the therapy.
Which is such an important point to make, because I imagine nimodipine really is only used in these patients. So I'm guessing they probably have pre-written, order sets that say, hey, 60 Q4 for 21 days. So if you reorder it and you don't change that, the chances of them, getting on extra days of therapy they may not need is probably pretty significant.
It's very high, yeah. So if you go to put in that order, it's going to go straight to 60 Q4 in 21 days from when you enter it. So, depending on what way that you keep up with patients, like we always enter in, the stop date that should be on their nimodipine, because it's going to happen that the dose is either going to be changed or it's going to be held for a little bit. So it's just it's an easy way to reflect back and be like, okay, what was their stop date? Because when they reorder, I'm just going to change the stop date back to what it originally should be.
Absolutely. I mean, 21 days in the ICU is like a year in normal time, right? So a lot of things can happen between now and then.
Yeah, and they don't always stay in the ICU for 21 days. It's usually at least 14. But yeah, they could be in the ICU for the whole time, or they could go home. Or, go to the floor. If they're doing it super well, then they may go home. Patients who are not having any signs, they were HS1, no deficits, then perhaps they could go home at 14 days or so. But it is usually they're with us for the long haul.
Mm-hmm. Now, kind of thinking of like alternate, maybe not routes, but thinking of, can we administer nimodipine, via like, any type of NG or OG kind of gastric or J feeding tubes?
So this is a very, very important point with nimodipine. It's important to know that it does come in two dosage forms. So there's a gel cap with the brand name Nemotop, and then there's an oral solution with the brand name Nimalize. So the oral solution was recently released, and prior to that, administering nimodipine gel tabs down an NG, OG, or DOP off was very difficult, if not impossible, right? So that capsule's not going to fit. So our nursing colleagues really had developed some creative ways to get the medication out of that gel cap. So I've heard everything of sticking the capsule under their armpit to putting it in the microwave to warm it up so that they could easily puncture this hard gel cap. The terrible thing about this is that the nursing staff to do this would take an IV syringe and puncture that gel cap to pull out the solution inside. And the problem with this is, nurses are busy. They have 101 things going on. And when they have an IV syringe in their hand, they're trained that, this is an IV medication. It's going to go in the IV route. And so a couple of times there has been inadvertent administration of this oral solution through the IV, which can lead to cardiovascular collapse and death. So many hospitals have, until the oral solution was commercially available, were taking that out of the nurse's hands and were kind of unit dosing their own Nimodipine oral syringes from the gel caps and producing them in central pharmacy and then delivering these syringes in an oral syringe to the nursing staff or stocking it in their automated dispensing devices. But now that we have Nimalize, many hospitals have switched over to this product. However, because of the expense, there are several hospitals that still continue to make their own from the gel cap. And we do have data saying that, the product developed by, or product that is made in the central pharmacy, you do get the actual dose, whereas sometimes if you do this at the bedside, although there are risks that the nursing staff may administer it via the IV route, but also they may not actually get the entire dose. They may not be able to get it all out. So if you are working at a place where you're still doing this, it's really important to kind of take that out of the nurse's hands because it's just extremely too risky to the patient. And then if you don't have enteral access, you just can't give Nimodipine. Like there's no IV formulation that we can provide. And from my experience, this usually isn't an issue. Like usually we do have patients, usually their gut works, right? So it's pretty easy to get enteral access of some sort, whether it's an OG or NG or a drop-off. So it's usually not a problem that they don't have access. But, occasionally we all have those patients who have some sort of anatomical reason that they can't obtain access, and we would just have to hold off on therapy until we can gain access.
Casey, you need to warn us. If there were any med safety pharmacists listening, I think they may have just thrown their phones potentially, hearing all the runarounds that the nurses could do with these, with the gel caps. The kids these days don't know how lucky they are because when I was training and I was in a neuro ICU, we didn't have those, right? You had to, and if you've trying to actually get that liquid out of there, I'm not convinced that barely anyone got their Nimodipine if they had to do it via NG, because it's just so hard to actually reliably get that out with the needle. So I'm glad that the study came out in 1989 and now it's 2020 and we finally have another formulation. So I'm glad they're keeping this on the forefront.
Absolutely. And I definitely have spent my time as a technician doing some unit dose Nimodipine. So even for the pharmacy staff, it's not funny and it's very labor intensive to try to get the right dose.
Now, focusing on prophylaxis for a bit, I think I may be less clear on when and how to use kind of specific agents in these populations. So when should DVT prophylaxis be initiated in these patients? And is it kind of business as usual in a sense where you can kind of use your normal DVT prophylaxis pharmacotherapy regimen, or should we be using kind of a specific agent and frequency?
Yeah, so DVT prophylaxis is very important in this patient population. So the incidence of lower leg DVT ranges anywhere from 1.5 to 24%. You'll see published. The incidence of PE is anywhere from 1 to 2%. And for the most part, we feel very comfortable starting DVT prophylaxis about 24 hours after the aneurysm is secured, either by means of coiling or clipping. For subarachnoid hemorrhage patients, the unique thing about their bleed is that we know exactly where they bled from. And now that has been surgically taken care of, then we don't really have a high concern for rebleeding anymore. And DVT prophylaxis should be safe. And we approach this patient just like we would a standard post-surgical patient, neurosurgical patient, when we start 24 hours after the procedure. Unfortunately, we don't have any specific data on which agent, whether it be unfractionated heparin or low molecular weight heparin, to use in aneurysmal subarachnoid hemorrhage patients. There is a meta-analysis in a general neurosurgical population that states that unfractionated heparin decreases the risk of DVT with both a BID and a TID dosing strategy, but there's no head-to-head studies comparing these two modalities. Additionally, that same meta-analysis states that low molecular weight heparin can be used. It may increase the risk of intracranial bleeding. Again, this information is from a meta-analysis with multiple types of neurosurgical patients, and we can say probably with confidence is that if a patient has undergone clipping with a craniotomy, then the benefits of low molecular weight heparin probably outweigh the harm, because we do know in the surgical population that low molecular weight heparin is probably preferred. We do have data in ischemic stroke patients that enoxaparin is superior, or low molecular weight heparin is superior to heparin alone. And most people feel that enoxaparin is superior in that surgical population, as I kind of mentioned from above. But that's really all the data we have at this time. So, takeaway is starting it at 24 hours. It probably doesn't matter which one you use. You'll have centers who are dead against using low molecular weight heparin in neurosurgical patients, but then you'll have centers who only use low molecular weight heparin. So it really is dependent upon the neurosurgeon's comfort level. And at this time, we don't really have any hard and fast data to take to them and say, no, you should be doing this. So it's definitely a hard thing to argue if neurosurgeons aren't comfortable.
Do you find yourself, if you're using low molecular weight heparins, that you're routinely monitoring anti-10A levels just to make sure that it's kind of in the range you want? Or is it more, you would more do that in kind of your special patient populations, whether over, underweight, renal dysfunction, what have you?
So at our center specifically, we have a protocol that basically encourages us to monitor people, like you mentioned, who are high weight, low weight, borderline renal function, or, very good renal function. We do have a couple of neurosurgeons who have kind of grasped onto the fact that we can monitor, and they find it completely absurd if we can monitor. Why do we not monitor for everyone? Just because not only is it important that we make sure that they are within that, range, which is debatable upon itself, right? Whether you're following peaks or troughs, but it is important to monitor from an efficacy standpoint. Are they in that range? Or from a safety standpoint, in the surgical population, are they above that range? And I think that a lot of them kind of hold on to that safety component. And I kind of agree. If we can monitor, why not? And if they're high, obviously that's going to reduce or increase their risk of bleeding potentially. I've gotten some anti-HTNs on little old ladies, and they are therapeutic at a very low prophylactic dose. So I think when we have these, if you have it readily available at your center, and you have patients who you're very concerned about, why not monitor? But again, I don't think there's enough data to support, widespread monitoring in these patients either. So probably cherry picking the patients that you have that are either at the highest risk of not being therapeutic or being super therapeutic, or a high risk of bleeding, probably are that bucket of patients that I would usually monitor.
Now, bleeding in the brain can also increase kind of the potential for a seizure. So is there any evidence for the use of empiric seizure prophylaxis, or is it typically added once you have a specific concern, or say, you think the patient might have had a seizure, then you would add on like an anti-epileptic?
Yeah, so this is something too that will be vary greatly from center to center, but we do know that seizures occur in up to about 20% of aneurysmal subarachnoid hemorrhage patients, and that's most commonly to happen within that first 24 hours of their ictus. And we unfortunately do not have strong data to support initiating seizure prophylaxis in these particular patients. And most of the studies do not demonstrate benefit for the use of prophylactic agents. But most of the trials, again, are small, have several limitations, whether, they didn't use appropriate dosing or they lacked level monitoring if they used phenytoin. And I would argue, given the current data compiled in the meta-analysis from 2017, that there is no evidence to routine use of seizure prophylaxis in this population. The issue with prophylaxis is that EVDs routinely lead to adverse events, up to 23% of patients in one study. And the utilization of prophylactic phenytoin can lead to worse cognitive outcomes at 3 months. So, if we don't have strong data for doing something, and we know we're putting these patients at harm, I don't really understand why we would continue to do it. But we do have guidelines that state from the Aneurysmal Subarachnoid Hemorrhage guidelines from stroke that do state that prophylactic anticonvulsants may be considered in the immediate post-hemorrhage period, and they do recommend against that long-term use of anticonvulsants. If the decision is made to initiate seizure prophylaxis, it does appear that maybe levetiracetam is better tolerated than phenytoin, and usually a shorter course of 3 versus 7 days is preferred, with absolutely no prophylaxis at discharge. And again, as you mentioned, these patients can develop seizures, and if they do develop seizures, then they would continue to be treated as they would normally. Usually when you have a seizure around an event like this, it doesn't mean that the patient would necessarily need to be on antiepileptics for the rest of their lives, but it is something that, they'll continue until they see the patient in clinic, and then they'll, wean them off as appropriate.
So many patients who present kind of with an aneurysmal subarachnoid hemorrhage, they're in this hyperdynamic state. And there are multiple kind of patient-specific changes that can happen because of that. And one of the ones that's going to potentially affect pharmacists the most would be augmented renal clearance. So how do we define augmented renal clearance, and do we have any idea as to how many patients kind of experience this phenomenon?
Yeah, so augmented renal clearance is one of my favorite topics, and I love talking about it. Generally, we define augmented renal clearance by a creatinine clearance of greater than 120, adjusted for body surface area in women, and greater than 130 mils per minute adjusted for body surface area in men. A lot of times you'll see centers just define it as greater than 130 for simplicity's sake, which is fine. The incidence in all neurologically injured patients is higher than you would think, and honestly, we don't know the actual incidence of all neuro patients just because it's so under-recognized and under-studied. I did help with a small study that I did while I was at UK Healthcare and working with Aaron Cook, but we found that specifically in aneurysmal subarachnoid hemorrhage patients, of the 20 patients that we collected on, 100% of those patients had augmented renal clearance, with their average creatinine clearance actually 325 milliliters per minute, which even escalated to an even higher number if the patient were to go into vasospasms. So the incidence is very, very high. We predict it's very, very high in this particular patient population.
And this study that Casey was just talking about, it's absolutely going to be on the reference list and is definitely a good one. Now, wow. So clearly we may not have a full idea as to the prevalence, but it certainly seems like it's happening probably more than we realize. So how do we diagnose it?
To truly diagnose ARC, you have to complete a urine collection. And you can do this over various periods of time. So in the study I just referenced, we did a 24-hour urine collection, but we do have data now that supports that you can get an accurate assessment with an 8-hour urine collection, and that should be sufficient to give you the accurate diagnosis. I would advocate that if you do not have an 8 or a 24-hour urine collection available at your center, that you can use the information that we obtain from monitoring drugs like vancomycin or aminoglycosides to help you identify if a patient has augmented renal clearance. This is originally how this hyperdynamic state was actually identified, is because we would be getting very, very low levels of these drugs that we can monitor. So we, started thinking about why, and augmented renal clearance is probably the answer, but you will see these drugs being cleared more quickly than you could even imagine and expect. And if you do see that, then you can probably assume that your patient has augmented renal clearance.
Yeah, this is the scenario where they're on, 2 grams every 8 hours of vanc, and the level comes back undetectable, and you're starting to wonder, what did they compound it right? You just have no clue how this can be happening.
Exactly.
Now, are there any dosing references to help maximize safety and efficacy, or should we just follow kind of one of the general, I think, critical care mantras, which is be aggressive, more is better?
Yeah, isn't that always the answer?
Always.
Yeah. So because it is such a new field of research and understanding, we really don't have any good recommendations or solid dosing references to help maximize not only efficacy but safety of various drugs. And I think each institution will probably make their own recommendations on, if augmented renal clearance is something that they're actively searching for or monitoring for, then they'll have their own dosing recommendations. So, for example, if I have a patient with ARC, then I'll be very aggressive on all dosing, especially those drugs which I can't monitor, right? So you think a lot about your beta-lactam, so cefepime or piperacillin tazobactam. I will usually, use the maximum dose that I can, or extend the infusion depending on what I'm treating. And then also with drugs like levetiracetam, if they're on it, I will go to Q8 hour dosing instead of the traditional Q12, just because we know that they're probably eliminating everything before we can even get to that next dose. And then I'll aggressively in these patients monitor anti-HTNs for their low molecular weight heparin dosing. And one thing that I'll highlight is that we don't traditionally think about how this is affecting drugs that aren't renally cleared. We are measuring their renal function because we can, but I like to argue that if the kidneys are clearing drugs quickly, then it's highly likely that we also have augmented clearance in drugs that are handled by the liver also. And we don't know why some patients have ARC or what even causes it, but it likely has to do with an increased blood flow to that organ. And if you have increased blood flow to the kidneys, you're probably seeing the same blood flow to the liver. And so that should also have us have an increased awareness of hepatically eliminated drugs. But we just don't know enough at this time on how to handle all of these medications or what even to do. But it is something that, if you have something that you're giving a patient that's very important, then it might be worth thinking about perhaps augmenting, hepatically eliminated drugs as well.
I mean, it sounds like this is one of the scenarios when you're involved with the care of these patients where you really get to pull out kind of the clinical pharmacist's tool chest and really use everything you can and all your knowledge, right? Giving those big loading doses, extending the interval. I'm sure you probably even have to do continuous infusion on some of these, maybe series to treat, potential infections or something like that.
Yeah, absolutely. And I think that this is part of the reason that these patients can be so fun for a pharmacist, right? A lot of the things we've talked about are securing the aneurysm and surgical and things that we can't necessarily participate in, but they can be very complicated, kinetic patients to dose and to take care of. And so I think it can be very fun for a pharmacist as well.
We've covered so much great information from, when these patients hit the door to, as they're, potentially transitioning through their hospital stay. What would be, some high level kind of take home points if you had to zero in on a few key factors for all of us to remember when helping manage patients who present with an aneurysmal subarachnoid hemorrhage?
Yeah, I think the first thing would just be our role in the initial blood pressure control when a patient comes in. So as we kind of mentioned, securing the aneurysm is the most important thing, but the first thing that we can do as a pharmacist is to assist with that initial blood pressure control. So, making sure that if you are an emergency department pharmacist, that you have the right tools in your toolbox, to manage blood pressure quickly if needed. The second thing I think would be understanding nimodipine, and it's currently the only agent that we have that has demonstrated improvement of delayed cerebral ischemia. It is important that we provide nursing staff either with the commercially available oral solution or prepare the oral solution by compounding in the central pharmacy to prevent this inadvertent medication misadventures if they were to happen. But, highlighting the safety aspects of nimodipine, I think, are very important, while also understanding that it is one of the only options that we have for these patients to help reduce their delayed cerebral ischemia. And third, I think I would want people to realize that the severity of cerebral vasospasm is real, and it can occur in about 70% of patients, but only about 30 will develop delayed cerebral ischemia, which is defined again as that symptomatic vasospasm. And it's very important that we pay close attention, even as pharmacists, to the goals set by the team, and specifically, focusing on blood pressure goals. So it may be counterintuitive to, think about how we were just at a systolic goal of less than 140 and changing the patient to a systolic of less than 220. However, this is one of the biggest interventions that we can make on these patients. So if you happen to see that you come in on post-op day one and we haven't really changed their blood pressure goals yet, that should be definitely something that we bring up on rounds, because it's really important to make this intervention very, very quickly. Because, we can see patients come in as a HS1 and they have a mild headache after their initial ictus, but they may leave, completely neurologically devastated by delayed cerebral ischemia. And so it's important that we continue to think about how we can help the team as a pharmacist. And so that first thing I think would be, identifying those blood pressure goals. And then, we didn't get to dive into the detail of all of this, but it is important to seek out information about the various other interventions that we have with pharmacotherapy, especially with intraventricular nicardipine or intraarterial nimodipine. Intraarterial verapamil. Do not put nimodipine in the intraarterial system. Intraarterial verapamil or milrinone, and really help your neurosurgeons understand, appropriate dosing and be a resource for them. I think that's probably the biggest things that we can do.
Well, I think that's all fantastic advice, and really, a good overview for anyone who hasn't necessarily treated or helped manage these patients. Now, as of this recording, we've been social distancing and quarantining ourselves, right, for just over about 2 months. So what have you been doing to kind of stay busy when you're not working? Has it been a pretty big adjustment for you and yours?
Yes and no. So luckily or unluckily, I guess, and I'm not sure how he would approach this, but my husband works from home all the time anyway. So he has been even more stir crazy than normal, because usually, it is that we will get out of the house in some form or fashion, since he's in the house all the time. I've got to learn a lot of tips and tricks from him on how to manage either getting out of the house or, being creative in some way. But one thing we have done is taken on some home renovations, which I'm sure a lot of people have done since they're in their home a lot. You start to realize all these things that you could or should do to your home. But we recently built a closet in one of our guest rooms, which didn't have one. So we learned how to frame and how to drywall and painted, which I'm pretty much a pro at this point by owning multiple old homes. But yeah, so that was a fun activity that we jumped into during quarantine. So it took us about 6 or 7 weekends, but we finally finished it.
You just casually mentioned that you're building closets during your quarantine. So now suddenly it feels like I haven't done a single thing in quarantine. are you two just naturally handy, or did you have a large amount of YouTube videos to assist?
I would say we're both naturally very frugal. And so by way it makes you handy, but yeah, no, we have zero experience, and it was a lot of YouTube. My husband's actually found his favorite drywall YouTuber out there. I can give people recommendations if they want. He lives in Vancouver, but but yeah, a lot of YouTube videos. You can learn a lot from YouTube these days.
When you have your favorite specific handyman on YouTube, that's when you know that it's definitely something that you all have done a couple times.
Yeah, or you have a problem. I'm not sure what it is.
So you definitely have connections to kind of lots of sporting teams, either professional or college, kind of throughout the country. Who would you say is your favorite, kind of your rooting team? Like if you, and I don't know, I'm not saying you're a tattoo person, but if you had to get one, what would the team logo be?
Oh, I don't even know if I could pick anything for a tattoo, but I think so. We're definitely college basketball fans, and I can thank the University of Kentucky for that. So I will always, bleed blue for basketball, but I also have ties to the University of Virginia. So very happy to see them be successful in the last tournament. So if the two of them were to ever play, I'm not sure what I would do. So don't ask me that question. But then professionally, really the only sport that I really follow professionally is football. And I am a huge Pittsburgh Steelers fan. I kind of grew up in the area of southwestern part of Virginia. So we really didn't have a local team, or, usually you pick a team based on, where you're from. But we had one of my high school, a guy I went to high school with ended up on the Pittsburgh Steelers team, and that's kind of how that grew. But I do enjoy watching some football on Sundays.
Well, you got to let the listeners know who this is, because he's not just some backup offensive lineman who you went to high school. Who did you go to high school with?
Heath Miller. Yeah, he was a tight end for he was a tight end for the Steelers for about 10 years. Yeah.
My in-laws are massive Pittsburgh Steelers fans, and I'm born and raised in Indiana, so I'm a Colts fan, and so they never let me live it down that the Steelers have the Colts numbers. Maybe we'll get football back, 2021, 2022 maybe.
Maybe, I don't know. It's a different world out there right now. We'll see what happens. But
at least you get to bask in the UVA recent victory.
I know, right? So does this mean they hold the title for 2 years in a row? I'm not sure.
Yeah, they're the only repeat college basketball title who only technically won one national title game.
Hey, we'll take it.
Casey, thanks again for joining me today. This was an absolute blast.
Absolutely. I love to spread the word about subarachnoid. It's one of my favorite patient populations, and hopefully other people find them very fun as well.
Now, what's your Twitter handle in case the listeners want to get in touch either with Nimodipine questions or their drywall questions?
Yeah, please do private message me about drywall. I'll forward you on to my husband. But I'm at Casey May PharmD on Twitter. And I'm trying to be better at Twitter and being very active. But yes, I will definitely respond and get back to you.
Well, thanks again, Casey. Have a good one.
Of course. Thank you.
I want to give another big thank you to Casey May for joining us today. And then also want to give a massive thank you again to you, the listeners, because this podcast doesn't exist without you. And as always, please send me feedback, either positive or negative, as well as any guest or topic ideas via Twitter or Instagram at PharmacyToDose, that's TO2Dose, or via email, PharmacyToDose@gmail.com. And on our website, PharmacyToDose.com, as well as in the episode description, you'll find links to the show notes as well as references. So it'll include background reading, guidelines, articles that Casey and I talked about in this discussion, and much, much more. Kind of building off last week or last episode, remember, call your mom, your grandparents, your friends, anyone. Definitely try to stay in touch in these difficult times. And until next time, I'm Nick Peters, and this is PharmacyToDose, the Critical Care Podcast.